wellbeing acorn, which is unique in the segmentation world. A lot of ICBs are very interested in this because you can then start to infer a variety of health and well-being issues in mind at a personal level. So the likelihood of smoking, alcohol, diabetes in a community, which will then help you understand people that are coming into hospitals, for example, where a child is growing up, the likelihood of them growing up in a certain environment. I'll now pass over to Gary for the ocean data.
Yeah, so our ocean data is individual counts. So what this does is at a specific postcode level, whereas Acorn, it's been, if you're Acorn Group A in London, you're Acorn Group A in Manchester, for example. Ocean is an individual count at that specific postcode. So information on, like you can see on here, digital connectivity, how much private medical insurance people have on that postcode, that's all counted for. It's very specific level. So it allows you to do a little bit more granular reporting and understanding of who's in your local community. Through the ocean database that we have. And then, yeah, that's good. Then we've got a few slides just to visualize how this actually looks on maps. So first, we're looking at Acorn here. Every different color that you can see is a different Acorn group. So we've got a real mix there in Ealing, showing you different groups. We've got professionals down to tenant living, all the way up to exclusive addresses. So you can start to see what your community could look like through mapping tools. One thing to note is while we do supply GIS tools, our data is agnostic. You can plug it into your own tools and you can analyze it that way. Next slide, please, Jamie. Similar to the household Acorn slide that we showed you earlier, this is just showing household Acorn again at the same place where you might see typically there are accomplished suburban families. There are some young professionals in there as well, so it's just making sure that you don't lose those. And then finally, if you move to the next slide, Jamie, we get our wellbeing Acorn, which again is showing the same area, but just shows that there's a different skew on it. You need to see what the wellbeing of the population is like. We have a few different groups on there as well again. So a couple of use cases and case studies that we've seen already. So NHS Blood and Transplant, we have a good working relationship with Gareth Humphreys there. I don't know if anyone knows it. But basically, they had a challenge recently around sickle cell disease. Basically, they wanted to be able to support more people with sickle cell disease, and the way that you do that is through blood transfusions. Normal blood transfusions, they become less effective over time, whereas there's a type of blood called RO blood, which is basically really good at treating blood transfusions, and it doesn't have that negative effect over the long period of time. So what they wanted to do is get more people donating RO blood. The issue they have is only about 2% of the UK population actually have RO blood, whereas in people of Black and Caribbean descent, up to 60% of those actually have RO blood. So what they wanted to do was get more people of Black and Caribbean descent donating blood. So if you go to the next slide, what they did is they had a look at our Acorn, our demographic data, and they used our Insight solution, which is our tool, to understand how they could change their marketing strategy and their marketing channels. And also they created a site matrix for understanding where they should open up a new donor centre. So what that highlighted was that Stratford and Shepherd's Bush were target locations for opening new donor centres, and they basically it's been a huge success. So Stratford is now the largest donor base of RO blood in the UK, and Shepherd's Bush is in the top 5. And by changing their marketing strategy, they've actually got a 22% growth in RO blood donations. So it's been very effective being able to use our data to the full potential.
And the last one is just to kind of go to that local government holding a certain area of Coventry City Council. Back in 2020, when there was that lateral flow testing, weekly benchmarks the council had to hit, there was an underrepresentation of a certain demographic that weren't testing, and they didn't really know who these people were. So they used Acorn to supplement that, to understand who were testing versus the people that weren't, and they built up kind of a target audience, more kind of the younger demographics that were less likely to test. So using Acorn and the Acorn knowledge sheets, they're able to understand who these people were, their channel preferences, their behaviours, especially how they like to be spoken to from a local service. So what they did, they ran a whole engagement piece on YouTube, because they knew YouTube was across the board the best way to engage with young professionals and young people. They also spoke with Positive Youth Foundations, again, promoting these, testing centre locations and locations where these people were more densely populated, signposting them to these areas. And just by doing that, they saw an increase of about 30% in lateral flow testing from these individuals just by understanding who these people are and how to best engage.
That brings us to the end of the slides. Any questions?
Anything from online?
I don't think so, so far, but,
Yeah.
So if you work for a trust, how do you get access to it, or as I assume it's available at ICT level?
It's available just at the ITV at the moment. If you want access to it from the trust, then let me know. We'll send our details around obviously after this, and we can set you up. Basically, there's subsidised prices for trusts because of the NHS being a partnership. But at the moment, it's just for the people at the ITVs that get access to this. Any reports that they create can be shared with other parts of the ITVs, the trust, and that sort of things. But the raw data itself is held at the ITV.
That would be available.
The federated data platform. Yeah. So yeah, the idea is that as soon as possible, basically, as soon as it's available. But for the time being, it's through CSU, Descros, where you can access that data.
And then, sorry.
That's right.
And so I know that the ICPs are working on a lot of similar things to potentially replacing doing, or is it education? Is it that for them?
I don't know what other things you might have talked about, but this is hopefully going to be replacing whatever they may have been doing before. I'm not sure what other data sets they may have been doing.
I mean, it may not be, but it's because we're being asked to do a lot of things internally.
Yeah.
As well, that are very similar to this. It's not really just being done. So at that level here, a lot of it doesn't need to be down at that granular trust level. So just that's my thinking. But yeah, if you could send details.
Yeah, we can pick it up on and go a bit more into your specific use case after this. But again, likewise, anyone can chat after this a bit more than all the discussion specific challenges that you've got. That's all.
Robert Sinfield, North East London ICB. This is brilliant news. I've heard a trail of it from a guy at NHS England before. We're doing segmentation, population health management, and this will augment that amazingly. Assuming it'll be patient level, there'll be a tag for a patient. We get all our hospital data at LSOA level and no lower. So how do we kind of, is there any sort of thoughts about how we aggregate to that level to sort of identify neighbourhoods for action?
So at the moment, as we understand it, the idea is the CSU or Desktop will be pseudonymizing that data and then send it, because they will have the full postcode data, which means they can link it. They can send it to you. I don't know how it's going to work in the data platform. I'm not going to lie to you. That's for us all to find out as we go along. But it'll be interesting to see when that does happen. We're happy to give you the postcode data, the raw level data. So we have no issues with providing you at that level of data. It just depends, obviously, in a mechanism, just how that actually comes to you. But yeah, we're more than happy to provide at any level.
We have one question online, and it's from Alan. Thanks, Alan. So it's, have you had any issues regarding inclusion versus opt-out? Did you need to get explicit permission to use individual data?
So if that's down to individuals at the time. So if you can use individual level data, we're more than happy. We're supplying it to you. That's an internal process on the NHS side that not to pass it off, but that's you to work out on your side. If you can use it, again, it's there available to you. And we've done our back end, basically. We're all GDPR compliant and everything like that. So there's nothing from our side that will be wrong. It's just that you're allowed to use it internally at the NHS.
So a quick question for me on DNA rates. As it states in use target any patient behaviour in terms of DDoS attend rates approval.
So you can profile, understand what makes up the group of DNAs, start to understand who they are, and then again change that messaging around it. I don't have any specific examples of it at the moment. James, who was using it?
I don't have any outcomes of it, but it's a new thing that they're starting to work on. Definitely, of who's coming in, who are these people, what are the things that's driving them in here, how can we move them online? So we have a conversation with ICB that's trying to move them online, or the GP services, rather than having to go in and use these services. We spoke to the exact healthcare in the Midlands that were looking for vaccination uptake from children, and who the likely people were for not taking their children to get a vaccination. Again, it's building that, I guess, customer profile of these people to then do the next steps of potentially mitigating that, doing into marketing or language and back end. So it's a variety of
In the interest of time, we'll move on, but just pick up on something you said about the webinars. How
Yes.
do you register or?
So what I'll do is I'll send that through to you, and then if you want to circulate it, it's to everyone here. So basically, we've got a registration page that you just need to put an email address and name, and then you can sign up, and then you get the invite for the set. Like I say, 2nd of May at 10 a.m. And more the merrier, feel free to share it. But yeah, it's
Thank you, guys. Really
Brilliant.
interesting. Thank you.
thank you.
Takes us on to Robert, and Robert's going to give us what I read wrong initially, and it perplexed me a little bit because I was quite interested to see how you're going to do some time travel analysis. So it threw me a bit. I never read it correctly. So now we do have Robert with GIS system and travel time analysis. So over to you.
Well, I wish I could do the former. I'll leave it on here. Just copy it. It's not big. I'll stay sitting down. So I like to see everybody. Okay, so I work for the ICB, as I said before. I've been knocking around the NHS for a long time. My second job was at the Healthcare Commission just around the corner 20 years ago. People in the room will know about that. So I've ended up at the ICB, information analyst all the way, but I've been a GIS specialist for the last 8 years or so. Did a MSc in it, been working quite a lot doing mapping, geographic analysis, stuff like that. Not only maps, but other things as well. So this talk will talk about other aspects of using geographic data that's not necessarily just the map. So we've used geospatial information to do your usual mapping about characteristics of the population, but I've got a bit of a niche thing going on with travel time information about measuring access to services. So, for instance, what are the most convenient service options for patients if one closes at primary care level, or the new services being in accessible locations? So we did a lot of work during COVID about placement of vaccination centres and coverage of the population by PCN level. Did the whole of London, supported that work. And this talk is mostly about how to use travel time information and some of the aspects about it that you might need to think about when you're using it. Some of its foibles, some of its limitations, and ways you can kind of help support decision making. So this project that this talk is based on, it's been going on for about 3 years now for NHS England. And it's moving a major paediatric cancer service from the edge of London into options for in the centre of London mainly, or kind of. So I'll talk about the context of that project, the characteristics of measuring travel time, and some visualisation and measures we can get out of that. So the project itself, Royal Marsden, Surrey, on the edge of London, was the home for this cancer service for kids, and I'm not sure the actual reasons why, but they're looking for options to actually move it to another site. So the main options that came out was St George's Tooting, St Thomas's Hospital, Waterloo, and UCL in Holborn. The service serves this huge area, sort of like most of sort of bottom half of southeast England, South London plus Kent, East Sussex, Surrey, bits and pieces of Surrey Shores, I think. And the question for us, they came to us and said they'd heard that we did some travel time information analysis. It's usually very expensive, that kind of work, if you get a contractor in, and we did it in the NHS, so we were cheaper. So they came to us and said, we need to work out what would be the effect of moving the services on our patients and the staff and the population. You know, how would access change? So 3 years ago, we started to look at this. The activity on the left comes from all over the area and actually other places. Staff that work at Royal Royal Marsden, Surrey, worked as you could expect, mostly close to the site, but they're spread around a bit as well. So we started to look at activity first about, okay, if this activity for like the last 2 years was going to Royal Marsden, what was the travel time to Royal Marsden, and what would it be if it went to the other sites? So to do travel time analysis, there's various options. There's ArcGIS Online, which is like part of the ecosystem of GIS software, but it only really does drive times or walking times. You can get, as we all know, Google travel times, but you have to pay for that. And I think it gets quite expensive after a certain amount of hits. And then there's a couple of other things that we've used. Base Map Track, which is like a industry standard travel time analysis software, which is very, very specialized. It's probably best if you're actually doing travel transport planning yourself, if you're changing things. So what we came down to be using was called Travel Time, which is like an API service. It's quite simple. It's got plugins for our software. It's relatively cheap. Does timetables, public transport travel time, as well as drive times, and it can do all sorts of things like walking times, drive train, just bicycle, that kind of thing. So when we're talking about travel time, what are we talking about? So how do we generally tend to measure things? So there's usually two types of things. So on the right, you've got your routing. So when you put your directions into Google, you usually get a route out of it. That's one. So that's like origin destination measurements. On the left is like a travel time area. So that might be like an hour outside of Great Ormond Street in that example, by public transport. So you can sort of see what the population coverage for that travel time area. Because this project started out looking at activity and patients and very specific sort of like relatively random organisation of patients, we wanted to look at very much point-to-point measures of travel time to see how they might be affected nearly down to an individual level. But obviously, there's some assumptions that the home of the patient is where they've travelled to go to the hospital. But you have to make some assumptions, which we'll come to. So in order to do the origin destination measures, the actual route measures, we need a starting point for the patient. So in ICB land, I just mentioned, we mainly have LSOA data. How do you measure the point from the LSOAs? I mean, LSOAs are useful because they last 10 years. Postcodes change quite a lot in year to year. It's a relatively good shorthand for an area, and what we came down to is fairly common in travel time analysis is to use the population weighted centroid of an LSOA, and that on its own acts as sort of like an average for an LSOA area. So if you're not aware of it, I mean, I think it's about 4,000 LSOAs we use to measure journeys to the 4 trusts as options for the service. And a population weighted centroid is basically in an LSOA. It's like an average of the distribution of the patients or the people across that LSOA. So it can sort of vary across the area of the LSOA. It can be different in different types of LSOA. And if they're more dense, it'll be in the centre. If the people that live in it are more spread out, it might be at one end or another. But essentially, it's like having a tray that's full of food. And there's a balancing point, and if you put your finger under the balancing point, that's where the population weighted centroid would be, population. So it acts as an average for the LSOA. It's not perfect, but it kind of, it's a good model. But like all models, they're all wrong, but some are useful, so it's fairly useful. So what kind of measures fit the task? So when we're talking about travel time measures and access, what do we mean? When you get down to it, there's a lot of questions about how you describe journey, how you might measure a journey, what affects it. We looked at driving and public transport, but we did a bit of looking at car train. So in the countryside, people were much more likely to travel by car to a station than to get a train to town. So we looked at that at one point. What time of day we talk about, peak or off peak? Obviously, different scenarios, different urban places or non-urban places have different peak or off peak traffic congestion or public transport access. Which direction you talk about? So we looked at arrival time at the hospital. So we generally went for midday on a Wednesday, so sort of like an average for the week. And the parts of journey. So do we need to include things about transfer between modes? So or bus, train, that kind of thing. So you can put in things like 2 minutes or 5 minutes for parking times and things like that. And then what are the best summary statistics when you're trying to describe journeys? Is it average? Is it weighted average, weighted median? What's the shortest, longest? Limitations, assumptions. There's a lot of limitations and assumptions about travel time information. Most of it's around that it only really measures the fastest journey. A lot of people want to say, well, I don't want the fastest journey, I want the average journey, or I want the slowest journey for older people or people with families or whatever. But really, you can only get the fastest journey. So it acts as a proxy. So it's a way to measure everybody equally. So like the fastest journey. That's what it comes up with. If you try to program in something longer, it just doesn't work because the algorithm always goes for the fastest. We were limited to 4 hours journey maximum. So some patients came from up in the Midlands and Manchester and places. So they were kind of like cut out automatically in some of the measures. There are things like, the algorithm in the API does change over time as well. So we have to tell people that want the travel time that in 6 months' time, there might be a new train service that arrives, like the Elizabeth line is a classic example, makes things faster for some people. Or they just improve the algorithm. So you just have to keep updating the output.
Sorry to interrupt quickly. What did the PT, some PT journeys, what does PT mean, please?
Public transport.
Oh, public transport, okay.
Yeah. And then if you're talking about faster travel times, if you talk about distance, faster travel times are not necessarily about shorter distances because of road speeds and train speeds. So Royal Marsden is very much quite close to the M25. So a lot of places can actually travel a lot further to get to Royal Marsden, but the travel time is quite quick because they go on the M25 to get there. So there's a lot of sort of getting people's minds in the right place about how to think about the information you're giving them. I've got till 5:30. Okay, so most importantly, the disclaimer for when you're thinking about travel time or what you're doing is that the measures are intended to provide an indication of the quickest journey, origin to destination, but there will because you're using an LSOA population weighted centroid, and I put this on all my output, journeys will not therefore be representative of all possible access from within the LSOA. Individual experiences may therefore not completely align with the analysis presented here. So everyone travels all the time and they know ways of getting places faster or whatever. This is a model, it has its faults, has its caveats, but it's the same for the whole area, and we'll just look at that. So that's one of the main notes we have to make. So when it came down to it, taking all that into account, this is what we needed to do: support decision making. So we needed to describe the journey times to the current site and each option, and we needed to quantify the change. So change from people populations going to Royal Marsden and what it would mean for them going to the other sites, St George's or Evelina at St Thomas's. UCL, I think, got carved off into a slightly different service option in the end. So there are two main options. So obviously, when we're talking about geographic things, maps are usually the first option you go to. They're useful for context, but then they don't really give you the answers. You can see on the left, I think that's the public transport areas to Royal Marsden. So that's up to 2 hours, I think, 120 minutes as the widest area that's indicated. And you can see on the right, the public transport travel time to Evelina at St Thomas, which is by Waterloo, which is obviously a greater area it covers in terms of like 2 hours range on public transport. But ultimately, this doesn't, it gives you some feel for what's going on. It doesn't really give you any answers that you can actually rely on. So we have to think about ways to describe traveling in summary measures. So this is the output from the algorithm. Basically, it's kind of dull. It's like travel time, number of seconds, you turn it into minutes, get a distance. Yeah, that's it. That's the data you get, really. You can turn it into a map, but the map's not that useful. It's really it's all. So you have to think about ways to get descriptive statistics plus ways to visualize it for our clients and for everybody, patients, everyone who's got interest in this story. So some of the things came up with was so a density chart, is it? I think it is. So this has got travel time along the bottom, public transport in minutes. It's got descriptive statistics on it. So it's got the median, 25th percentile, 75th percentile. You can say like 75% of journeys are within 132 minutes. 50% are within 95 minutes. So it's a way to visualize the extent of the journeys, where the peaks were in terms of the numbers of journeys or the numbers of people that were able to travel at those times. And then we could use it to describe different aspects. So we had like London only on the top, and non-London obviously has generally longer travel times. We use weighted medians, because if you use you can see on all of these, it's got a tail at the end, so you get quite long travel journeys at the end. So if you use just a normal median, it might skew it. So we weight it by population. And then we did things like, yes, did the same thing for staff, ethnicity, urban, rural, deprivation. So the qualities analysis, we're looking at, are there any particular groups that are losing out? Any things we rummaged around in all of that, and the NHS England took away the information and regurgitated it into a report. Other ways to look at the data are, this is fairly obvious, so compartmentalizing it up into 15-minute journey time. So percentage of the population that are within 60 to 75 minutes, 20% in this measure. And then we also turn that into cumulative travel time. So we can say that 72% of IMD1, the most deprived, are within 120 minutes of the site we're talking about. So this is St Thomas's site. You're hurrying me. I'm sorry. And then that chart on the right, the cumulative chart, is quite good for actually comparing different things. So you imagine if you're trying to compare two of those charts on the left, one obscures the other. But if you're doing a cumulative chart, that one shows two things. It shows IMD1, deprivation quintile 1, sorry, and deprivation quintile 5 alongside each other. I think going to the top left is better. So for that particular measure, that's actually 2 to 5. I think IMD1 was slightly losing out on this measure, but generally they didn't, because the sites for St George's, Thomas's, which are in quite highly deprived areas, so deprivation in London was covered. One thing we needed to do is also quantify the change. So when you're talking about change, people expect kind of, it's not really easy on this sort of scale as well, because things work in different directions. Public transport can have a different answer to driving. And one of the things that people immediately think is that people further away from the site will lose out. That's not necessarily the case. So what it is usually the people that are nearest to the site, the original site, that lose out. So this chart, just briefly, is on the bottom. It's the travel time from Marsden, the current site. On the left-hand axis is the travel time change to, in this respect, Great Ormond Street, which was one of the very early options. It never got taken up. And if we look in the top left-hand corner, that's the, so yeah. The people that had the biggest change, the biggest additional travel time were in the top left-hand corner, and these are the people that were very near to the site itself, the original site. So it's almost always the people that live near the original site that lose out on travel time, just a percentage of increase. Other ways of describing it. So this illustrates the thing between public transport and driving. So the top measure is driving. So on the top chart, the orange on the right hand side is increased journey times, and the green is on the left is decreased journey times to an option, whichever option it was, Guy's and St Thomas's. And you can see the majority of activity in this example were having longer drive times to St Thomas's. It's not surprising because St Thomas's is by Waterloo, so it's going to take a long time to drive there. Public transport wise, it's the opposite direction. So you can see a lot of green on the left. Guy's and St Thomas's is by Waterloo. Very easy to get to, but from a lot of places, a lot easier than Royal Marsden Surrey, which is usually a train and a bus or something, or driving. So as you can see, if we talk about travel time and different modes, you get different answers depending on which way you're looking. In the end, the main measures that the project looked at was whether or not populations and activity were put out by plus or minus 15 minutes. That was felt to be a reasonable change. You can see from the chart on the right, the table on the right, that for driving, there's an increase of more than 15 minutes for 70% of people if you're going to St Thomas's rather than Royal Marsden. For public transport, 70% of people had a better journey of 15-minute reduction in their journey, or at least a 15-minute reduction. So this is the sort of dichotomy of travel time results. You have to be very careful about how you interpret it, and sometimes it's very, very difficult. And then briefly, finally, we looked at times of the day. So we found that, or I found that in London, if any journeys to sites in London, St Thomas's or St George's, it didn't actually make that much difference what time of the day it was. If people left early, they'd hit traffic at some point. If they left later, they would hit traffic anyway. I don't know, in London, I used to live in London, peak times are often actually like late mornings. Everyone's just arrived in London and the traffic piles up. So we found that peak and off peak didn't actually make that much difference in travel time, for driving at least anyway. And then finally, we made lots of reports. So we looked at both just the travel time itself, and then we did a drive time analysis on costs. So we did cost per mile, 16 pence per mile, which is the government their recommended amount. We did 4 reports for NHS England. They took all the information and wrote it up and made decisions on it. We were no part of the decisions. So yeah, they kept coming back over 3 years. Hopefully it's finished now. I think the consultation's finished. Some people around the table might know more about that than me. I don't know. So yeah, that's it. Sorry, whistle stop tour for time's sake, but questions.
Thank you. Very good presentation. I had 2 questions, but on the very last slide, you answered one of them because I was going to ask you about attaching costs to it. So that's very good. Thank you. What mapping software do you use?
We currently pay for a license for ArcGIS, which is Esri, ESRI. They're expensive, very, very good, and they have an online platform you can use. But there's QGIS or QGIS, which is free and open source. Which
I've used QGIS in the past.
And then we use R, Python sometimes to do certain things. There's a thing called Geo Data Analysis, which is open source, which is really quite brilliant. So we use a range of things. So, happy to have a chat about it at some point. Thank you.
Any more questions?
That is so interesting. I could have like thousands of questions, I think. But I wanted to check about the difference between like whether there was something about like the change from driving to public transport. And like I live in Sutton, and I feel like pretty much everybody apart from me drives everywhere. So I wondered if like the difference in the change, because yeah, I appreciate that the public transport would get quicker. But if you're not taking public transport in the first place, that's quite a big kind of behaviour change to factor in.
Yeah, so in the end, we went for driving for the costs, especially because it's paediatric cancer services. People are recommended not to travel on public transport because of getting infections. So we went for that. It is very difficult to bring the two together because people say, well, why don't you say like 30% of people might go by public transport and 70% might go by driving. So come up with like a mishmash and an amalgam of that, but it's really hard to do that. I did a study when I was doing my MSc on A&E. I'm trying to model access to A&E by travel time. There was only one survey at the time that asked people in A&E how they got there. And I think it was in Havering or somewhere, it was like 20% of people went by public transport and 80% drove. But in Newham, it was almost the other way around. It was like 50% went by public transport. So you can't really second guess it, really. So you kind of have to sort of present the results of both modes and come up with like a reasoned consideration of it.
When plotting your maps, do you use postcodes or easting and northing?
For
your map, for your mapping software and your when you're plotting distances, because easting and northing coordinates don't change, but postcodes will change over time. You get new housing developments and they get new postcodes, don't they? And so your software is always sort of playing catch up to sort of
so just quickly on that. So two things. So we use LSOA centroids, so they're constant for 10 years. So just use that as a proxy for the area.
Yeah.
We use sorry, it's network. I didn't say earlier. So like the travel times are always the network. So it's like if it's drive time, it's not as a crow flies, it's on the roads. And public transport is actually bus travel times change onto a train. So it's a network travel time. It's not as a crow flies. So a drive time, drive distance will be distance along the roads. Thank you.
One final question. Because you mentioned the outcome of it, and the outcome is it's coming to the Evelina Children's Hospital at GSTT because it was announced last month. So thank you for your work. I didn't know they were going to see that.
Right. So yeah, I've stayed out of all that. It made the HSG at one point.
Yes. On that bombshell, I'm very thankful to everyone. So thank you. Takes us to not last but not least to Jamie. Jamie's going to talk us through some analytics approach for health insights from South West London ICB.
Thank you. Oh, that's is that okay?
Yes.
So I've got the last bits, and I'm the Deputy Director of Analytics in South West London ICB. So I'm going to talk through, there's no case study, I'm going to talk through the art of the possible. So when you take data on the ecosystem from Cappy, these are the kind of things you can do with the data. I'll pause there for a minute because I've got the last shift here, so I'm wearing a little slightly for you. So can I just get everyone to stand up for a second? It's difficult. I'm used to, I've got a 10-minute attention span. I think cartoons when I go with about 10 minutes long. Very different now. So if we shake your hands for a little bit, spend a minute or so doing this. Keep steps. People online, and that's what I'm doing. I've got my deputy here. Nick, can you make sure the office is standing up as well? Just take a few steps as well. And that's it. I won't make any press up to anything. It's just to. So I hope that works. So all I'm going to do is talk about population health management. So very different question of data. We can choose as much data as we can get our hands on. And we've been doing this for quite a few years.
You need
Yeah.
So these are the things I'm going to cover today. I'll talk about what population health management is, what a patient-centered approach looks like. I'll talk about what lots of data looks like. Most of this session is about storytelling, and then a bit of ask for help as well, right at the end. So if things go well, I'm happy about that. I'm not doing any case studies today. We've got a whole load of examples of how to use this in the future. So this is very much visualizations. In terms of data, these are all things we've got hold of. Not capped yet. Very keen to come on board. So we've pulled together as much data as we can. We've got primary care in the top left, acute hospital, community, mental health, one-on-one referrals, patient lists, everything we can get our hands on, we put it in there. And that's all at patient level. And I'll talk through the architecture in a moment. And the important thing about doing that is the demographics at the top right. So when we bring all those data sets together, we get a good picture of what the population looks like. So we know what the gender of the population looks like, the age, the ethnicity, definition, and so on. The big thing here is there's a risk if you take any of these data sets in isolation, because if you use things like primary care data, you might have about 60% of your population's profile. By bringing it all together, our population is 1.7 million. We've got 95% coverage of the population look and feel. So when we do an inequalities picture, we're very confident about what that looks like. The 5% that are missing from our cohorts are patients that opt out. So we can't do anything about that at the moment. And again, we've got things around mortality, workforce, bottom left, some of the environmental accessibility pieces. And I'll show you how it looks like in a moment. And the further thing we've got in the bottom left, bottom right, is all the segmentation and our AI model. So there's just too much data, and this can't fall through it bit by bit. So lots of risk of admission, frailty indexes, likelihood of passing away in our mortality index. And with more data, there's more we want to do. So we want to in-house some of our risk stratification models. We wanted to do that as a community as well, because some of these are quite expensive. And a brief touch on what architecture looks like, because we're analysts. So I mentioned all of our data is linked to patient level. So patient right in the middle, we can see nearly every line from that links to the patient. So everything from weather, incidences, and traffic reports all go back to that patient level identifier. And that allows us to do patient level analysis as well. We're running this now. So more data is good, but why? So it allows us to better understand the patient's interaction with healthcare, to understand patient needs, helps us understand outcomes as well better. More data points mean we can create better stratification in the AI models, and combining data means we get that 95% coverage of the population. All fantastic things. And big thing we have is a single data model, and that creates one version of the truth. So we're an ICB. Our next step is to democratize this data. We need to get all these data sets into providers, mental health hospitals, and primary care as well. So that's our next big step. There is a risk to loss of data, and that's data quality. So some of the data sets out there are less mature than acute data. So things like mental health and community, a few more years to go before they get to where they need to be. So we'll see you turning off in a second. Okay. We're now going through some of the visualizations we use. So infographics, an easy one. These are useful because they're static. They can be published, they can be emailed around, and they can go into the public domain as well. The good thing is they add accountabilities. When we create a infographic, it goes to comms. But what we can do is come back in a year's time and see if things have improved.
Into that. You should be something.
I think that would say.
That's working. I'm probably changing.
I'll carry on until it turns off. So, we now start to look at some of our interactive reports. So we try to make everything intuitive. The use cases are varied. So what we try to do is empower the analysts, give the analysts all these tools to talk to colleagues. We also get the end users to access these dashboards as well. So the look and feel of these are very important. It needs to be intuitive, and we bring that entire data model into this. So what you see here is an IMD deprivation view of South West London. Everything on the page is clickable. So you want to drill down into an ethnicity, an age band, you can click down almost to a patient level. And we get asked often, can we cut it by X, Y, Z? The answer is usually yes. So what's hidden from here is a lot of filters. So you can drill down to gender, health profile as well. If we start to bring in the CAPI things, we can actually filter this by who reads the newspaper, for example, and get a very detailed picture of what the system looks like. So other things we look at are some more inequality stories as well. So should see the map around there, showing you that drill down. So if you want to understand what your local population looks like, the analyst here sticks on our whites. And then our mixed population, you can see everything interact. So you can see that depending on what you look like, quite literally, that population tends to live in different parts of South West London. Again, you can click down to heart's content, so you can see the cohort numbers changing at the top there. Travel times, well, it helps start with this actually during COVID. So one example we have is accessibility to sites. So with the end user in mind, we ran this during COVID to understand where best was to set up a pop-up site for our communities. And this highlighted a lot of vulnerabilities that weren't targeted in the system, and how to set sites in the right place as well. So again, bit different, it's not static. It allows users to pick between public transports, cars, and really helps us target some of the local populations as well. You can see the light colours are your shortest travel times. Darkest, quite fast some of these, but we found out that the furthest away tended to cars again. So very different targeting technology there. One of the big things we did during COVID with all this data, and it's a big success, we managed to convert our Asian population from the least vaccinated in society to the most vaccinated in society over 6 months. And if we had some of the CACI data, that would have been amazing because it would help us understand what kind of media that population consumes. Religion as well, we found very hard to get hold of. So the more data we get, the better we can understand in public patients. This now starts to look at some of the segmentation work we do. So looking at pathway analysis, groups of tens and hundreds of patients. I think it was clicking through there. And so it starts to group them into what a high-risk patient looks like versus a lower risk. So the aim here is to target the more untoward pathways, particularly the ones where we think we can modify the outcomes. So give the end user an idea of scale and the kind of the services that the patient's going through. So obviously, if someone's going from the GP to A&E, back to GP and A&E again, it's a very different picture that we need to target.
So that, look, it's Stephen.
Yes,
In
it's
that
Stephen.
middle panel, there's a green button.
Um, this shows you the most granular level of reporting you do. The TV's not good.
If you want to try that
Yeah.
side, there is I think there is a microphone there, so it should be able to hear from there.
So this shows the most granular level of data that we've got. I'll click on it. It should move. There we go. So you can see an analyst clicking through the visuals. Every click, every row is an individual patient. There we go. So each square there's an interaction with healthcare. So the sky's the limit here, and we've got mental health data in there on the one and the A&E activity. So this again is the most granular level. We use this for practice of the GPs to help them understand the kind of pathways they're going through. So highlighted to them if there's anything very recent that's popped up, if a patient's going through a mental health crisis, for example, this will start to flag it and give the clinicians the broader picture of what's going on in the health ecosystem. Again, we can put in things like warnings, triggers, health measures as well. So a patient's blood pressure spike, for example, we could put that into here as well. So every double click. And then we can also do outcomes. Difficult to see from here, but we can also measure health outcomes as well. So on the screen on the left are patients that have seen a social prescriber in the past year or so. On the left shows the health profile of those patients 12 months before seeing a social prescriber. On the right is the health profile 12 months after. What you can't see from here is that there's a marked improvement in treatment targets. So the likelihood of patients meeting treatment targets for diabetes has drastically improved since seeing a social prescriber. We obviously can't contribute all of that health improvement to the social prescriber, but it's a good indicator that something's improved. Next step is to put together a pilot group to see if that has really benefited the patient. But the big takeaway is that, yes, social prescribers, interventions do work, but we can also prove the opposite. I'll click on that. And click again, it should start moving. So very lastly, I've just shown you lots of separate tools. This is what it looks like when an analyst is given all these tools to play with. And the idea is they can sit in front of their consultant and just narrate the system for them. So I think this is a respiratory picture. So it's looking at looking for your respiratory population, looking over time and seeing very quickly that depending on the year, it's a very different age group. And I think it goes to ethnicity. So a very different age and ethnicity group being diagnosed year on year. So you can see here in 2017, I think it is, that those being diagnosed with asthma or respiratory tended to be much older. And going through COVID, that changed very quickly to a younger population, but very different pictures between ethnicity. And then again, more towards looking at the age they were diagnosed, it's showing off very different pictures depending on where you are in South West London. I think that's near the end. Oh, this bit I have to walk up for. So, next, I've shown you lots of visuals, lots of capability. Very hungry for data. We do need help. We're not one team, we're not one big team. We need a community behind us as well. So what we want to do next is democratize the data. Everything you see here, all the way down to patient level, we want to give back up to the system. It's no use sitting on my server. Those that can make change in our data. So even simple things like when you go to a GP, they actually know what's happening to the hospital half the time. We want to give our data back to them. Everything from when the patient scored 111, and this the pop-up sites as well. We haven't got the architecture yet. It's not cheap. We can work together. There's lots we can do. I want to open source all of this. Those simple things like how we decided the ethnicity of patients. It's not easy. patients' list is changed depending on the forms are available on the day that are not dictated. So we've taken some methods to test into the system. We're very keen to get the source or get some peer reviews or whether that looks like, or there's something that needs to change. Patient opt-out, you could be, we haven't got IS yet, so single welfare opt-outs, about 1-2%, which we can deal with. We can put some reporting layers at the top to add that 2% back. Some welfare opt-out about 80%, which that's from now in some of my analytics. I don't know whether or not to just do that in total. But that's a conversation we just got together. At the moment, just let it as it is. Risk there is patients that opt out are very healthy. They've never had any problems. Data. We also must get hold of children and young people social care data next. It's sitting there. We don't know. I can say there is, yes. Again, we can do it once. Share the intel. And exceptionally reporting SPC, that's what wants to move into next because that's just shown the whole range of data, still not so much data again. So we're going to think about. And lastly, risk algorithms. I'd like to get community together to look at some of the risk algorithms. So also how much if you go to the demonstrated events, Power BI. But again, once to take that, again, you can set some improvement by us doing it for ourselves. And that's it. And again, no case studies there, just the art of the possible. I'm more than happy to come out with specific case studies and talk through what changed services.
Absolutely super. Really good presentation. Thank you, Jane. Were there any questions? Are there any online that we've had?
Not so far.
Even at the table. Oh, sorry, Alan.
This is actually a question to several of the presenters. I've heard quite a lot of people suggesting democratization and
Either you're on mute or our sound has gone. Alan, 1 second.
I'm not on mute.
I can hear Alan.
Yeah. Yeah, it's the little round one. That one. Press it in.
Hello?
Or hit the green button.
Can you hear me now?
I think we might have you now.
Oh, okay.
I think we might have you now. Try again.
Oh, thanks. Yeah, I was saying there was a number of presenters talked about democratization and sharing data and trying to create bigger data sets. And I was wondering if any of you are looking at standardization techniques to allow different trusts with different systems to integrate things like OMOP, which is what we are looking at UCLH at the moment. So that even though you've got your observational data recorded in quite different ways depending on your electronic health record, you're still actually able to produce data that will come together and work as a cohesive data set.
I think we only got part of that, right? You can write that question again, please.
I'll write it in the notes and somebody can get back to me.
Okay, thank you.
There's another question on the chat from Colin. It's just wondered whether you had any thoughts on how diet, the access to fresh versus UPF food in the community might inform the HO models.
Diet.
Food. Yeah. The access to fresh food or processed food.
I think that's a khaki thing. So khaki's got a lot. I've seen things like it can tell you if you're more likely to keep tap running when you brush your teeth.
Yeah,
lots of, I don't think these people are, but they've got data like that. So once we bring that in, that really helps things like our obesity dashboards. Yeah, for diets. we have information on like how many, like how happy are they, how satisfied are they with their diet? Do they get enough fruit, like 5 a day sort of thing? So there's information in the data sets that we can help obviously add to what you're doing as well.
No more questions? Oh, one more.
Because with the travel time stuff, consider work for the same place. Right? So is it something that was collaborative between the two different places? My main question is, so I didn't introduce myself, Sean Hession, for free. It's just how replicable it is. What's the development time of the kind of work that you're doing around travel times and to work for something together on this? But is it something that you helped with, that you replicated, or something you did before?
I provided a set of big table, didn't I? I think for you to use. So it's quick. It's probably the deciding what to do with it and how to interpret it is the long bit. So you can get very quick figures.
We tried to do something similar when I was, gosh, it wasn't as sure it was that. So it's kind of yeah, I was very impressed with how we did that, and it looks like it was used really effectively for that. So yeah, seeing how it's something we tried to do with similar things overall free as well. So yeah, it'd be interesting to find out more about that.
Yeah, I'm happy to have a chat outside. Yeah.
Yeah, so it's data, then we do the visualizations. So
Yeah.
keep passes again.
Yeah.
More data, Kathy as well.
Yeah, exactly. Yeah, that'd be good.
Jamie, thank you ever so much for that. You particularly for managing to cover our job thing. We nearly made it all the way through, but not quite. Lessons for the future. So I'm going to hand back to Ramika now, just to close us off
Yes,
for the meeting.
yes. So the last slides. So, thank you. So the future dates for 24-25 in July, the 2-day AphA conference again in Birmingham, slightly different locations. I think it's slightly middle of nowhere. So, but if any of you are attending, it would be a great opportunity. And in October, there's a Digital Health AI and Data Conference in London Olympia. I didn't make it last year, but I understand that it was a really great session conference. And then we will have in September some AphA London branch meeting. And the date will be confirmed by Roger, and we will be having it at Guy's and St. Thomas's. Once Roger secures a room, he will let us know what day. Joining us. Thank you, Alan, and others for great questions. And I would like to close the session. Thank you very much. For timing. Yeah. Eric.
And the video. Here we go.
Here we go.